Good morning, everybody. I'm thrilled to be here. 15. We missed one for COVID. It's wonderful to look out in the audience and see friends and supporters who have been here for all of those years. My discussion today will be about enhancing rotator cuff outcomes. So I guess the first thing that matters, and as we get into the weeds of what really means a better outcome and who perceives a better outcome, is to question, well, what really matters with respect to the rotator cuff? And does healing of the tissue entirely matter? It seems that you don't need complete healing to get a good outcome or to develop a pain-free shoulder. But if we look under the hood a little more carefully and deeper into outcomes, those individuals who have fully healed their tendon will report better strength and more normal function. And that follows common sense, right? So with that in mind, we need to identify, as we move into 2024 and 25 and forward, we need to identify ways that we can make healing and outcomes just that much better. And what's daunting or inflicts humility is that if we look at this study, which evaluates the number of studies done in rotator cuff surgery from 1990 to 2015, you see this big blue line. And asymptotically, there's this huge spike in the number of publications that examine how better to treat rotator cuffs. But at the same time, if you look at the purple line, it's pretty darn flat from 1990 to 2015. So despite thousands of articles on how to do a better job, perhaps we're not doing that much better. Now, not to be a pessimist, the outcomes are still quite good. But the question is what are we actually doing that makes a difference? So in my mind, how to enhance outcomes. There are patient factors, meaning what the patient's medical issues are. There are tear factors, when we look inside the shoulder and see how complex or how shredded the rotator cuff is. And there's rehabilitation factors. There's strategies on how we as a group and the therapists in the room, how they can better identify to recover and enhance outcomes. So just like in every other field, we want to have predictive modeling. We want to know what the factors are related to the rotator cuff itself that can help us predict, will you heal, will you not heal? It's not so obtuse, it's not so much taking your thumb and sort of assessing and analyzing, although your gestalt is part of it, but there are ways that we can look at certain criteria on the rotator cuff and put a score on it. And if we score your rotator cuff, I can suggest that, if you're in the green group and you get a low score, you have a 94% chance of healing. But once you get into the sort of red or pink score situation, somewhere between 14 and 38% chance of healing, well, if you know that as a patient, you might say, well, I don't know if I want to have this surgery if my chance of healing is only 14%. Or furthermore, I know that if I have a 38% chance of healing, a lot less than half, let's think of some strategies that are going to make me heal better, that are going to enhance my outcome. So, of course, before surgery, anything we can do to optimize the patient health and range of motion and muscle quality. So pre-op range of motion and strength is important. Pre-op health optimization, for those internists in the room, we really need your help on getting the hemoglobin A1C or the diabetes under control, because we know as your blood sugars are out of control, healing will be lower. Nutrition. This is such an aha moment, but left alone so often. It is quite simple. Vitamin C, vitamin D status, magnesium, these simple elements, if you start them before surgery, can quite simply enhance your chances of healing. Adding the right amino acids afterwards can help. And of course, smoking cessation, which is a little trickier, but nutrition, that's an obvious one. We should preoperatively and perioperatively maximize our nutrition. Then, look, it is a surgical discussion, so we have to get into some of the surgical features. We want to do a repair that's not under a lot of tension, and understanding the anatomy of the rotator cuff is so important. This is a study I point out all the time, and I think as a student of anatomy for 20 years, I would know this, but constantly relearning, reteaching myself, re-understanding the anatomy of the rotator cuff so that I could put the jigsaw puzzle back together in the appropriate way. When we fixed these, we started doing these 25 years ago or so at Greenwich Hospital, we would use one simple anchor and one simple stitch, and it was hard to see and hard to get it done. Now, 20 years later, we've got maximized configurations. We're using 2 rows of fixation, we're using thicker constructs, and we're able to really anatomically repair the rotator cuff back down again. So biomechanically, many of those studies that I talked about earlier, we figure out how to do this. We can technically make a very good widget. Now, can we biologically make a good widget? Instead of using regular suture material, how about adding biologic suture material? suture material that wicks and pulls all those stem cells out of your bone, suture material that's made of collagen, which is basically the elements of rotator cuff. So this is going to be the next thing we look at. It's going away from regular stitches to using collagen stitches. And that will be true in all tendon repair all over our body. And this is not, it's coming. It's here now. And it's incumbent on us to prove that it's effective or not effective. What about adding your own cells? Well, in the OR, you'll see many of us aspirate from the iliac crest or take blood product and spin blood product back down in to add to the healing. And the simple reality is that when used appropriately, adding the right stem cells, adding the right platelet cells can truly enhance outcome. And it seems to make even a more important difference in those situations where we have revision surgery. Another thing that we've been working on is using your own biceps tendon, your own autologous tissue. So here is a video where I'm looking at a very torn rotator cuff, and this is actually a really bad biceps. And what we'll do, instead of cutting the biceps and believing that it's just a pain generator, we'll use this biceps, which look, was very vascular. I don't know if you saw that blood supply coming out of it, but we'll use your own biceps as an autograft, meaning its own graft, its own way to augment and enhance the rotator cuff. So I'm releasing the biceps from the groove right there. You can see the structure. This is this torn rotator cuff over here. And I try and set it down or reduce it just like a fracture into the right position. But you can see that tissue is a little thin and flimsy. So what we'll choose to do here is take the biceps, the patient's own biceps, remove it from the groove and lay it down. And right there, that is its own graft of tissue. It's its own source. Instead of adding a secondary graft or a patch, it's also got vascularity. It's also got live cells. So rethinking some of the things that we chose to do 20 years ago, where we thought the biceps was always a pain generator and always a problem, maybe now it's going to be our friend and be a source of live cells. There are numerous studies which show that this will actually enhance the healing rate. As I said earlier, healing seems to matter. We use other patches in the rotator cuff when the biceps is not available. And if I remember back to repairing your bicycle, when I take a patch and repair your bicycle tire, in the same way, we have different patch materials made of different materials, such as human skin, which can be useful, collagen, or even xenograft tissue. And all of these have slightly different roles in inciting a healing response. And we don't use them all interchangeably. There are certain times when I have good tissue and I just want to get more healing. There are certain times when I have bad tissue and I want to augment the mechanical strength of the tissue. But these rotator cuff patches will, once again, I think in the next 5 to 10 years, become more mainstay. And you won't see them in just the rotator cuff. You'll see them in the Achilles tendon. You'll see them on the quad tendon. Ways that we can biologically harness our body's power to heal. This is a quick video on using a dermal graft on a skin graft.
Case of revision rotator cuff repair.
And what you'll see here, as I move to it, is after I finish repairing the rotator cuff, I'm taking a piece of dermis, human skin that has been prepared and very safe, and we'll weave it together. And look, it can be a little tricky. It's sometimes hard to get this in right, but there's lots of industries out there who are making these devices easier for us to use. I'll wrap it tight around this inserter device, and then after I've repaired the rotator cuff, I'll insert this graft into place. It's about 2 millimeters thick. And really what's interesting about dermis or skin is that it's very porous and cells can quickly grow into it. And it's amazing to see how well this will incorporate. It doesn't turn into active tendon, but what it does is it thickens the tissue and allows the sutures to sort of stay in place. So there I lay it down just like a carpet into place, and we can sew them into place using many of the arthroscopic techniques that we use. Here's a really neat video. In this video, you can see a graft put in, and the patient had a slip and fall and tore their biceps afterwards. So here we had the opportunity to look at this graft 6 weeks later. So here's the graft put in initially. Lays down, you say, gosh, that looks okay, right? It's straightforward. But look at it 6 weeks later. It's incorporated, it's got red, which means it's vascular, and really we see the body accepting these things relatively quickly. So not only does it make scientific sense, but look, we can see empiric evidence that we're able to strengthen and augment rotator cuffs. And look, we don't want to go back in on patients and visualize these things, but this is just a fantastic example. We talked about the autologous biceps. Finally, the last part, I talked about the tear factors, physical therapy factors. We have to have appropriate use and appropriate protection of the rotator cuff after surgery, somewhere between 4 and 6 weeks. We have to have appropriate protection during therapy where things aren't moved too aggressively, but at the same time, an intelligent way to wake up the other muscles that surround the shoulder so you don't atrophy so much. So I think this is also a critical part. So in sum, we can be better. We can be better at rotator cuff surgery. We can improve pre-op motion. We really need to focus on preoperative and perioperative nutrition. We can predictively model. I can tell you what your chances of healing are just based on your factors. We can use better repair constructs like the double row fixation. We can add your own biological stem factors. We can add patches. And finally, we can put in the proper rehabilitation. So thank you so much. I'm excited to be part of the number 16 this conference.